Today, we will be talking about pathologic bow-leggedness, also known as Blount's disease. What is bow-leggedness or Blount's disease? Blount's disease is a pediatric genoviral deformity. Blount's disease is a developmental disorder characterized by disordered growth of the medial aspect of the proximal tibial physis, resulting in progressive lower limb deformity. Although it also referred to as tibia vara because the varus coronal plane deformity is most distinctive, the disease usually results in multiplanar deformity of the limb. The deformity consists of varus, procurvatum, and internal rotation of the tibia. This pattern is a result of the asymmetry of disordered physeal growth, most pronounced in the posterior medial aspect of the proximal tibial physis. Blount's disease can also be associated with limb length discrepancy, and in some patients, deformity of distal femur as well. Blount's disease is a condition found in children. It affects growth plates around the knee. There are two types of Blount's disease. The first one is called infantile Blount's disease, also known as pathologic genoviral. It is more common than the adolescent type. Bout legs relatively normal in children under age 2 and generally improve by 18 to 24 months. However, in infantile Blount's disease, bowing does not improve and instead worsens over time. Generally, it is seen in children 2 to 5 years of age. Males are more likely to develop said condition than females. It affects both legs 50% of the time, and deformity is in the tibia only. The second type is called adolescent Blount's disease, also known as adolescent genoviral. It occurs in children over 10 years of age, and this more likely affects one side only. The deformity typically occurs in both the thigh bone and the tibia. The etiology of Blount's disease is thought to be multifactorial. Mechanical overload and genetic susceptibility are considered risk factors. Mechanical overload leads to osteochondrosis of the medial proximal tibial physis and epiphysis and later progresses to a physical bar. Overweight children, in particular in specific demographic populations such as Hispanics and Blacks, are reported as more likely to develop this condition. Although the exact cause of Blount's disease is unknown. Children with infantile Blount's disease are typically early walkers and often overweight. Adolescent Blount's disease, on the other hand, may be related to rapid weight gain or obesity. So how can it be recognized by the patient or by the patient's family? So you have to look for trouble walking or awkward walking pattern in toddlers, turning in of the feet or in toeing with bout legs in toddlers, and knee, hips, and ankle pain in adolescents. Presentation is more commonly bilateral but can be asymmetric. Multiplanar progressive deformities of the lower leg includes tibial varus, procurvatum, internal torsion, limb shortening due to altered growth, and distal femoral varus in late onset. Gait abnormalities includes increased knee abduction, increased medial load to the knee, and early onset knee osteoarthritis as a result of deformities. Warning signs includes the family history of Blount's disease, and if your child began walking at the age of 10 months or younger, which may have put excessive pressure on the growth plates. Walking with difficulty or discomfort, walking with the feet pointed inward instead of straight ahead, and difference in limb length. So when you are supposed to seek consult? Mild bone changes can be hard to spot in kids younger than 2 because their bout legs might be normal and straighten out on their own. It is easier for doctors to diagnose Blount's disease in kids after age 2. What should you expect in a visit to an orthopedic surgeon, laboratory, and other diagnostic and confirmatory tests to be done? For physical examination of genovirum or flexion or internal rotation deformity, it may exhibit positive cover-up tests. This is usually bilateral in infants. It is also often associated with internal tibial torsion, with leg length discrepancy. There's no usual tenderness, restriction of motion, or effusion. There's also noticeable lateral thrust on walking. The diagnosis of both forms of Blount disease is based on history, physical examination, and radiography. Laboratory studies have not been shown to aid in the diagnosis of Blount disease. On knee radiograph, characteristic changes associated with Blount disease can be visualized, such as medial beaking of epiphysis, widened irregular medial epiphysis, irregular ossification, and medial slope of the epiphysis and metaphysis in varus. A standing anterior-posterior radiograph is taken with the patella facing forward for full assessment of the coronal plane deformity of the limb. Measurements taken on radiographs include metaphyseal and epiphyseal angle, the metaphyseal and diaphyseal angle of the proximal tibia, and the tibia-femoral angle. MRI has also been used to assess tibial and extratibial abnormalities in children with infantile Blount disease. What are the possible treatment options? In infantile Blount disease, orthotics may be used. Custom-molded braces may be used in mild cases of Blount disease or rickets, but are not tolerated by most children. This type of treatment may last up to 18 months. It can also be corrected surgically. Through the use of hemiepiphysiodesis, it can induce temporary rest and guide growth. It slows the growth process on one side of this growth plate and can give a gradual correction of the bowing as the child grows. This procedure is done using a small plate and 2 screws that will straddle the growth plate. The procedure is simple with minimal blood loss and is reversible. This may take up to 6 to 12 months and is corrected gradually. After the procedure, the child may be able to walk upright while no cast or braces are needed. For adolescent and infantile Blount disease, surgery using external fixators can be used. This is corrected gradually using an adjustable frame, an adjustable external frame to the bone with wires and pins. The parents of the child are then given a regimen which outlines the daily adjustments that should be made to the frame. After the correction, the patient will have to be admitted to the hospital to remove the frame. Another surgical intervention is performing an acute osteotomy. This will be done by cutting the bone and full correction in the operating room. The patient will then typically have a plate with screws inserted internally to stabilize the cut bones and will be put in a cast for a period of 6 to 8 weeks until the bones unite. The patient will not be able to walk to ensure the correction will not be lost. What are the consequences of neglect? The prognosis for Blount disease varies greatly between infantile and adolescent forms. Infantile Blount disease has a good prognosis and deformity recurrent rates are low when condition is treated at an early age. Without therapy, disease has progressive characteristics. Later stages continue to progress and eventually lead to joint degeneration. In the late onset form of the disease, regression does not occur and the varus deformity may worsen over time. These patients may develop sequelae as a result of joint malalignment. For complications, as the infantile variety is a severe one, it progresses into permanent deformity if left unattended at its early stages. So early diagnosis is a must for this type of variant. For adolescent variety, it also causes deformities but less severe compared to infantile variant.
That's all for now. See you again next time.